Hi guys, this is Dr. Chirag Wagh from Mumbai, a gynec laparoscopic surgeon, and today we're going to be discussing a few salient features of entry techniques in laparoscopy done for gynecological surgeries. Now when it comes to entry techniques, there are various types of entry techniques that we can use. There is the Verees entry technique, there is the open type of entry technique also called the Hassan's entry technique, and there is also the direct trocar entry. So these are various types of entries and people have their own personal preferences as in which entry they choose to go for or opt for, and usually everyone is trained well in at least one entry technique. However, I feel that it is essential to know at least two entry techniques quite thoroughly, because if one fails you can easily go on to the other one. Now the entry technique that we are most familiar with and what we will be discussing in today's video is that of the Verees needle entry technique. In my opinion, the Verees needle entry technique is a very safe technique because it gives you a fairly certain idea of being in the abdomen by the pressure readings that you get, which is why when you're using a Verees needle for entry, it is very important to have a good insufflator giving you good pressure readings, because they are the ones that are going to tell you that you are into the abdomen and not anywhere else. So when you're connecting the gas there, you need to know where you are by the pressure readings that you get, and we'll come to that in a bit. So the Verees needle basically looks something like this. This is the Verees needle. It has a spring mechanism at the back, and this is a disposable type of Verees needle. It has a spring mechanism at the back, a sharp end at the front, and a beveled end. So as you hear the clicks going into the abdominal cavity, you hear the clicks because the sharp end gives way and the beveled end comes forward. This prevents any injury to any vital structures that may be there. In the Verees needle entry technique, the point of entry that we always prefer is the palmer's entry point, usually. That is 2 fingers below the subcostal margin in the mid-clavicular line. And that is the area which we prefer because it is the area where there are least likely to be any intra-abdominal adhesion. So when your Verees does enter, it should not enter into the bowel or an adhesion. And the major vessels are far from there as it is, because they are in the midline and we are entering away from the midline. Now one essential thing to remember, or rather two, are that in a Verees entry technique at the palmer's point, you need to be very sure that there is no splenomegaly first, and secondly you need to be extremely sure that there is no stomach insufflation during the anesthesia process. So if your anesthetist has ventilated the patient or given a bag mask before intubating, then there is a very high chance that the stomach gets insufflated and gets filled up with air, in which case it can come to lie below your palmer's entry point and your Verees would enter directly into the stomach. Now that should not be an issue usually, because the Verees has a very small bore and it does not really cause too much damage, and those nicks also, those injuries in case they happen to the stomach, do heal spontaneously later on, and you don't need to take a stitch as a mandatory rule, but it is always preferable to avoid such complications if possible. And in case the anesthetist says that he or she has insufflated and there is a chance that the stomach may be filled with gas, then you can always request them to put in a Ryle's tube. So that decompresses the stomach sufficiently and your entry becomes very safe. Now, when you're entering, you will be hearing a few clicks. So just place the Verees perpendicular, take a stab incision, place it perpendicular and hear your clicks as you pass the layers. You'll get 2 or 3 clicks typically, mostly 2 clicks, and as soon as you feel the loss of resistance, you stop. Don't unnecessarily push the Verees in too deep after you have lost the resistance, because the next click that you get after that would be the retroperitoneum and the major vessels, so that should not be done. Once you get the 2 clicks, you have to do the tests. So the tests are basically, first you do the aspiration test. You connect a syringe filled with say 5 or 7 ml of saline and you aspirate. When you aspirate, you need to get bubbles, because the peritoneal cavity is an empty cavity. You need to get bubbles. If you're getting blood, bile or urine, then that is not a safe entry. You need to just stop and switch. If you're getting bubbles, you push the saline into the Verees needle and do your hanging drop test. So when you push the saline through the syringe at this level, you can actually see that it is a transparent reading here. So when you push the saline, it should drop in level and go into the cavity, because the peritoneal cavity is a cavity which has a negative pressure. So it pulls the saline into it, and that is your hanging drop test. If these 2 tests are good, you connect your gas pressure, you connect your gas tubing to the Verees needle and you start your gas. At this point, it is very important to see the gas pressures that are shown in the insufflator at that moment. The ideal pressure which we use should be less than 6 millimeters, and the flow rate that you have set on your insufflator should be more than 1. If it is anything other than this, there could be a few other possibilities. First could be that you are pre-peritoneal, as in the layers of the abdomen, and you have not entered the peritoneum as yet. In that case, you need to withdraw and do a re-entry into the peritoneum, because otherwise you will have an extra peritoneal insufflation, and that will cause a lot of issues during your surgery itself. Second possibility is it could be hitting some structure like the omentum or maybe the small bowel or something. In which case, if you're sure you've entered, you can just lift the abdomen and shake it a little to drop that structure off. But then your reading should normalize. If they don't normalize within say 3 to 5 seconds, then it's more advisable to just take the Verees out and do a re-entry, because it makes no sense to just play around there. Now, coming to the next one is that when we enter, we usually in our unit prefer to take the 5mm accessory port on the left side first and enter with a 5mm scope. So this is the apple trocar that we use to enter from the left side 5mm. So you choose that point, you enter your trocar, remove the trocar, and then enter with your 5mm scope. When you go in through the side port, you can actually see the center. Why we don't put the umbilical port directly is because if the patient has had some previous surgery or has had a prior infection, there are very high chances that the omentum could be adherent at the level of the umbilicus or the small bowel. If that is the case, you can easily visualize it through your 5mm port, do an adhesiolysis, and then do your primary entry. After all this is done, you enter with your 10mm port, insert it, take your good head low, drop your pressures, and then continue with your surgery. All ports are always to be inserted under vision. Never insert your ports blindly. If you do that, you're going to land up in trouble. The set pressure that we use for our entries is usually 18, and then after doing all the port entries, we switch it to our operating pressure, which is 12 to 14. That is what we practice in our unit. Now what we'll do is we'll just go through a video of this whole process so we get a better understanding, and I'll see if I can give a few talking points there as well. So as we can see, I'm entering at the palmer's point in the mid-clavicular line, 2 fingers below the subcostal margin. I have taken my stab incision there, and now I'm checking my Verees needle for the spring mechanism. Now I will fix it to the rectus sheath and then pass as I hear the clicks. I have heard the last click at this point and I'm stopping pushing because I've got the loss of resistance. Doing the tests at this point, aspiration test seems good, the hanging drop test is also good, the fluid is flowing freely into the cavity. Now I will connect my gas tubing to the Verees needle and check my pressure readings. So the gas tubing is connected without moving the Verees needle, and then gently we start the gas and get the pressure readings. So it seems like a good intraperitoneal entry with a pressure reading of 3 or 4 and a flow rate of 1.5. So we increase the flow rate, although Verees bore doesn't really allow a flow rate of more than 2 liters per minute. Now we wait till the pressure gradually reaches a 18 set pressure that we've kept for our entry, and then we will be entering with our ports. Just checking the pneumoperitoneum and marking my spot for my left 5mm accessory trocar. I have marked my spot and taken my incision at that level. Now I will be inserting my 5mm accessory apple trocar. Fixing it on the sheath and going in with a purely rotatory movement. Avoid direct thrusting movements because they can be dangerous. When you open the outlet, you should hear a free hiss of gas at that point, which ensures that it's a good entry. And then you can remove the Verees and connect the gas directly to the port. Insert a 5mm scope and then just ensure the entry by seeing your screen at that point. Thank you.